decompression device. I've done a right good bit of research on this for this presentation. This device was developed by Dr. Ian McNeil, who was a trauma surgeon in Europe. So the problem that people have found with these traditional catheters that we use, they're very flexible. They bend easy, they kink easy. So you've got a patient that's been shot, you've decompressed him, he's very anxious and everything, and goes moving around, and your decompression needle catheter becomes dislodged, or it becomes kinked, and then the patient develops tension pneumothorax again, resulting in you have to re-decompress the patient, causing them a little bit more anxious and everything, because everybody's going to be anxious when they're coming at you with a 14 gauge needle. So the ThoraQuick, I couldn't find a real good picture of the catheter part. The actual cannula that stays in the patient is similar to a hydraulic hose that has wire woven into it. That way it's a lot stiffer. It stays embedded in the patient, it's harder to kink. This part right here is actually your one-way valve. You go that way, once you take your needle out, you go up to release air, that way to close it off, and then that way you can draw back if you need blood or anything. Under each of the three wings here, because it's in a triangle form, there's kind of like a steri strip, like the doctors use to close up a wound or something. You pull the steri strip and it secures everything. That way there's no this trying to pull or pack bulky dressings around your needle decompression catheter to keep it from dislodging.
Okay. On these right here, you know, being in EMS, we all know that cost for equipment has a lot to do with the type of equipment we use. What's the cost versus your regular standard required that we use now, and this? What's the cost difference?
The cost here, surprisingly, was only $181 per catheter, which I was very surprised.
What is that?
These, I'm not sure, but being as all the EMS services in America use these, can't be much. Probably about like IV catheters. You know, they can buy them in bulk, a big box of 50 or so. So, but ThoraQuicks are about $181 per one use. So a little bit expensive. I would really love to see these on a lot of the trucks. It would create a, you know, something else we can use, you know, a little bit more user friendly.
Does have an expired expiratory date?
That I'm not sure, but I would imagine so.
With it being so rigid, would it affect the inflation, the reinflation on all?
I don't think so, because the video that I saw when I tried to get it attached to my presentation, but the technology was not for me that day, it would move back and forth, but it wouldn't kink like these catheters. So it's not rigid like a piece of PVC pipe like you think, but it'll move back and forth with the thoracic pressure and the lung movement, but won't kink like this catheter will. Cook needle decompression kit. This is another one. I've actually heard of a couple of services using this. Has a needle decompression needle, has a tubing with a three-way stopcock here. That way, for some people, they like drawing off blood off of a hemothorax. That way you can direct that into a biohazard bag. Has the syringe that you can attach to the top of your needle decompression needle. Your Chloracep, your iodine swab, a couple other little things, some tape, that way you can secure it. These here were about $320 per one use. So unless you work for a very large city system that has a lot of money that they can put into some nice shiny stuff, you're probably not going to see these on the truck. Asherman chest seal. This was developed by a Navy corpsman. I tried to find out the year, but the patent year had a lot of conflicting answers, so I didn't include that. Like I said, it's a chest seal. It's a vented chest seal. That way, if the patient has a sucking chest wound, the air comes out, and then when the patient inhales, it closes as to not introduce air back into the pleural space. Halo chest seal. These are getting a lot more prevalence in EMS in America today. These are the ones I was talking about. Some services protocol for a sucking chest wound, completely seal the chest and decompress both sides. So like I said, the new studies are showing that to completely seal the sucking chest wound off and decompress is a lot more beneficial than Asherman chest seal, which is a vented chest seal. Hyphen chest seals. Actually, I have used some of these in the field. They're aggravating. They will stick to everything. They are worse than any petroleum gauze could have ever dreamed of being. This is the happy medium between a vented and unvented chest seal. Even though it sticks to the patient, if I had one to show to you, when you open it, the sticky side has ridges in it where blood and anything else can escape. So it's similar to the Asherman and similar to the Halo and just really aggravating to use. So how do we decompress? Decompression, very, very invasive procedure. You are introducing this needle and catheter into the patient's thoracic cavity, into the pleural space. You definitely don't want to drop this in the floor and be blood and dirt and everything else and then pop the patient's chest. That could cause a lot of infection, a lot of problems for the patient down the road. So step one, prep your site. I have my, So, we have a patient here that needs to be decompressed. We have absent lung sounds on this left side here. Patient doesn't appear to have any wounds up here. He was involved in an MVA. Our primary site is what we're going to use. So we want to cleanse the site. First thing, try and wipe as much of debris. You know, after a wreck, patients usually don't have a lot of dirt and everything on them. Wipe away as much of that as you can. When you do this, like I said, this needs to be as sterile as possible. Use an iodine-based solution. Chloracep, any of those iodine-based solutions will definitely help. So go ahead, cleanse your site with iodine. So then, we've done all that. Let me get to the next slide. Okay, yes sir.
If you said this patient is involved in an MVA and he's been hit in the chest, what would you do if that chest was flail or cracked ribs as well?
Cracked ribs, you would apply bulky dressings and tape it down. That's what we were always taught. Go ahead and put bulky dressings, secure it as best as possible.
Would you decompress the same area or would you move to another site?
If it's flailed right here, you know, this side, if you decompress on this side, it's really not going to help that much. So you can try and go for this side. You know, always, you know, you have this side, but always remember you have a secondary side. Okay, so we've got our tools. Make sure that you've got plenty of bandages on hand because, you know, you definitely want to make sure that you can see everything. Monitor your patient's vital signs. Make sure you've got all your tools that you need and they're within arm's reach. All right. Always also tell your patient if they're conscious what you're about to do. Anybody that has any sense, if you start coming at them with this needle, they're going to be scared to death. Tell your patient, like, you know, sir or ma'am, you know, you have what we think is, or we think you have what is called a tension pneumothorax. We need to insert a needle into your chest cavity to evacuate the air. It'll help you breathe a lot better. You know, don't worry, we're going to give you the best care that we can. Never mislead your patient in any way. Step 3. Once your site has been cleansed, you go there, your clavicle is your first, there's your second rib, there's your third rib. Right on top of your third rib, at a 90-degree angle, when you go through the chest wall, you could hear a rush of air. Some paramedics also like to put a 10 cc syringe with a little bit of normal saline in it and they like to watch for the bubbles. That shows that the air is being released from the pleural space. Make sure it's in there, thread your catheter, pull your needle out, dispose of your needle into a sharps container. Hold on to that, and if you have an Asherman chest seal that has the adapter, you can put it on there. Some people like to, before they insert the needle, to take a finger of a glove, put the needle through it, and it'll act as a one-way valve.
Question,
Yes, sir.
how deep do you go? Like when you're advancing it, do you go all the way? Is there resistance to a certain point?
Depends. Like if I have a 90-year-old or a 90-year-old woman that's 105 pounds, that would just about go most of the way through her. If I had her, you might only be able to go like that. Then you could pack bulky dressings around it to make sure that your catheter doesn't go anywhere and leave it like that. So step 4, attach your one-way valve or 3-way stopcock, reassess your lung sounds and monitor for tracheal deviation. Like I said, if you use an Asherman chest seal and it has the adapter where you can put it on top of the hub, use that. Rapid transport to the nearest trauma center, consider air care if possible. Here in rural Bladen County, if you're out in the middle of Kelly and it's 2 o'clock in the morning and you've got a patient that's been shot, definitely when you go, you might want to have air care on the way. Definitive care for the trauma patient is the surgeon. Even though you've managed this patient and everything, as we were always taught in paramedic class, trauma is definitively fixed by a surgeon. That's the definitive care, is trauma surgeon ready and waiting. So what have we learned? Needle decompression is used in the treatment of tension pneumothorax. Needle decompression is a very invasive procedure. Tension pneumothorax is a serious condition that can lead to death if not treated properly. There are several types of kits and tools that we can use to manage a patient with tension pneumo, such as the Thoraquick, the needle decompression kit, Asherman chest seal, halo seals. Your primary site is the second intercostal space. Secondary site is your fifth intercostal space. Your only definitive treatment for trauma is surgery and the proper way and steps to manage a patient with a tension pneumothorax as we demonstrated. Questions and comments? Remember, the only stupid question is the one that's not asked. Any questions at all?
So you would use a mid-axillary needle decompression if your sites weren't available here, or, you know, if
Yes,
you have a
ma'am. You would.
preference? This is the one you wanna do first?
Yes, ma'am. That's the one that, all the protocols I've read, they always want you to go mid-clavicular first. Then, if this site's unavailable due to an embedded object or the patient has wounds up here that prevents you from doing a needle decompression, you go to your site. Any other questions?
Is that because the surgeons want you to, like the old way they call us an IV, where you got veins in your, start with the veins in your hands and leave the veins up here for the nurses if you can't get IV, is that the same reason?
Pretty much. I have seen chest tubes done up here. I've also seen chest tubes done in the mid-axillary location. Like I said in the previous slides, some doctors say that if you decompress on this side, that takes away their ability to do a chest tube on that side. I've also heard trauma doctors say that I'll just pull it out and pop a chest tube right there where you done the needle decompression. It depends trauma center to trauma center, doctor to doctor, but the protocols now that we have, your mid-clavicular site is your first site, and your mid-axillary site is your secondary location if this one is, for some reason, you can't access it. Any other questions?
Do you see a increase in the amount of people that, say, in a traumatic arrest situation, now we can go ahead if we think they may have had
tension.
tensions, we can go ahead and just pop them even though they're, like if they're in PEA or something, as
Yes.
a resort. That's just doing it, get it over with and see.
Yes, that is, because when you go through the ACLS class, T is one of your things, tension pneumothorax, to see, you know, if you have a patient in PEA, try and decompress them. It might work, it might not, you know, but that's going through ruling out your H's and T's. So that's a very good point. You can do that in cardiac arrest and trauma arrest and all. Might work, it might not, but, you know, trauma arrest, you do everything you can. Any other questions? All right, thank you.
Very good.